Finals SAQ 90 Prematurity. A 12-week-old male baby presents for a unilateral inguinal hernia repair. He was born at 30 weeks gestation. A. What are the specific perioperative concerns in this baby? Apart from the fact that it was very preterm, you have no other information about the baby's condition or when it left the NICU. Thus, write down all the issues that may affect a baby born this early. This baby was born at a stage when organogenesis was ongoing and is therefore at risk of immature physiology, consequences of whatever treatment it had due to its prematurity, and issues associated with low birth weight. An assessment must be made as to whether it is appropriate to proceed with elective surgery at this stage or whether to defer until a later stage. Airway. Complications of previous prolonged intubation, such as Malaysic airways, stenotic airways, risk of difficult intubation, and need for smaller tube diameter. Increased risk of airway obstruction due to laryngomalacia, tracheomalacia, subglottic stenosis, and tracheostenosis. Respiratory. Bronchopulmonary dysplasia, apneas, respiratory fatigue, risk of respiratory failure, and consequences of oxygen toxicity are potential issues. Bronchopulmonary dysplasia. This is chronic lung disease of prematurity. Usual definition is oxygen requirement over 36 weeks post-menstrual age. Pathophysiology caused by interruption to lung development and lung injury. Conducting airways, alveoli, and surfactant development is still ongoing at the time of premature birth. Premature delivery results in stiff, non-compliant lungs, VQ mismatch, and potential need for ventilatory support. Lack of surfactant in premature infants increases surface tension at the alveoli, leading to alveolar collapse, respiratory distress syndrome, and if artificial ventilation persists for more than 28 days, there is increased risk of bronchopulmonary dysplasia due to volute trauma, barotrauma, oxygen toxicity, accumulation of secretions, and pneumonia. Outcome is lower lung compliance, increased oxygen requirement, obstructive lung disease with reactive component, increased susceptibility to infections such as bronchiolitis. Patient is prone to perioperative bronchospasm and desaturation under anesthesia, and pulmonary hypertension. Treatment is with antenatal steroids, surfactant, lung protective ventilation, and NIV. Next is apneas. This is defined as cessation of breathing for 20 seconds or more, or if less than 20 seconds but associated with bradycardia, cyanosis, or pallor. Premature babies are at increased risk of central, obstructive, and mixed apneas, attributable to immature ventilatory control, failure to maintain airway patency, or both. Central apneas can occur due to reduced chemoreceptor sensitivity, reduced central response to hypoxemia and hypercapnia, change in the response to hypoxemia, and exaggerated inhibitory responses to laryngeal stimulation or lung inflation. The following factors increases the risk of apnea: less than 60 weeks post-conception, sedatives and anesthetic agents, opiates, stress, pain, hypoxia, hypo or hyperthermia, hypoglycemia, sepsis, anemia, airway injury, lung pathology, neurological disease, heart failure, and prostaglandins. Patients at risk of apnea necessitate overnight admission for observation, with monitoring such as cardiac and SpO2 monitoring, impedance pneumography in an appropriately staffed environment. Treatment includes conservative such as positioning, appropriate ambient temperature, exclusion of concurrent illness, treatment of risk factors, and supplementary oxygen. Further measures includes nasal CPAP, humidified high-flow nasal cannula, and methylxanthine stimulants such as caffeine or theophylline. Premature babies are at risk of respiratory fatigue. Increased work of breathing occurs due to inefficient chest wall and lung mechanics, coupled with increased minute ventilation due to high oxygen requirements. Hypoglycemia and reduced proportion of type 1 muscle fibers in the diaphragm increases the risk of fatigue. Risk of respiratory failure is due to the above-mentioned anatomical and physiological features, high oxygen demand, and blunted compensatory responses by anesthesia. Premature neonates are vulnerable to cellular damage from oxygen toxicity, Cytotoxic reactive oxygen metabolites overwhelm their immature antioxidant system. Oxygen toxicity may lead to bronchopulmonary dysplasia, retinopathy of prematurity, intraventricular hemorrhage, periventricular leukomalacia, necrotizing enterocolitis, kidney damage, and hemolysis. Cardiovascular implications for prematurity includes increased risk of cardiac defects, difficulty in vessel cannulation, immaturity of the neonatal myocardium, and need for individualization of blood pressure targets. There is increased risk of all cardiac defects and delayed closure of ductus arteriosus in premature babies. The three most common cardiac defects includes PDA, ASD, and VSD. PDA is the most common cardiac defect and often persists in premature babies. It can also reopen under conditions commonly associated with anesthesia, such as hypoxia and acidosis. Consequences of PDA includes left to right shunt, increased pulmonary blood flow at the expense of systemic and coronary circulation, pulmonary hypertension and cardiac failure with low diastolic BP, pulmonary hemorrhage, pulmonary hypertension, bronchopulmonary dysplasia, intraventricular hemorrhage, and necrotizing enterocolitis. Treatment of PDA includes medical, fluid restriction, diuretics, non-selective COX inhibitors, and paracetamol. Surgical treatment includes surgical closure. Difficulty in cannulation may occur due to previous multiple cannulations and small fragile vessels. Considerations for the neonatal myocardium: it is important to maintain normal heart rate and rhythm, as the ventricles are non-compliant due to higher ratio of fibrous to contractile tissue in neonatal myocytes, leading to a relatively fixed stroke volume. Therefore, increase in cardiac output for neonates is dependent on increasing heart rate rather than stroke volume. Avoid overfilling of the ventricle, which increases wall tension, reduces coronary perfusion, and may lead to myocardial ischemia. Maintain normal calcemia to preserve inotropy, as the neonatal myocardium relies on extracellular calcium rather than intracellular stores. Neonatal myocardium is less sensitive to the positive inotropic and chronotropic effects of catecholamines, as baseline beta-adrenergic stimulation is close to maximum. Regarding blood pressure targets, tailor to achieve adequate perfusion and delivery of oxygen, guided by adequacy of end-organ perfusion. Prematurity is associated with congenital deformities. Congenital defects increases the risk for premature delivery. Assess for cardiac abnormalities, Vectorial syndrome, which consists of vertebral defects, anal atresia, cardiac defects, tracheoesophageal fistula, renal anomalies, and limb abnormalities. Assess for Charge syndrome, which consists of coloboma, heart defects, atresia coanae, growth retardation, genital abnormalities, and ear abnormalities. Neurological implications for prematurity includes intraventricular hemorrhage, need for good pain control, anesthetic neurotoxicity, bilirubin and cephalopathy, and retinopathy of prematurity. There is increased risk of intraventricular hemorrhage in premature babies due to structural immaturity and inadequate cerebral autoregulation, leading to fluctuations in cerebral blood flow. It usually occurs within the first few days of life. Risk factors for IVH includes hypoxia, RDS, hypocarbia, hypercarbia, extremes of blood pressure, rapid fluid shifts, metabolic derangements, and hypertonic infusions. Complications of IVH includes ventricular dilation, hydrocephalus, parenchymal infarction, cystic periventricular matter injury, and cerebral palsy. Periventricular leukomalacia is a strong predictor for later cerebral palsy. There is need for good analgesia, as pain receptors develop by 20 weeks, and pain pathways develop by 26 weeks gestational age. And fetuses beyond this age demonstrate stress response from stimulation. Early exposure to painful procedures may result in structural changes, demonstrable on MRI, and poorer motor and cognitive outcomes, but more research is needed to confirm this. Thus, only essential surgery should be performed in early life, and ketamine should probably be avoided in premature babies. Regarding anesthetic neurotoxicity in premature infants, results from studies such as GAS, PANDA, and MASK suggest minimal impact on neurodevelopmental outcomes in otherwise healthy babies undergoing a short general anesthetic. However, there is also clear preclinical evidence of neurological injury caused by anesthetic agents over prolonged or repeated exposure. Collaborate with the carers and responsible teams to advocate for the right procedure at the right time. Bilirubin encephalopathy is due to unconjugated hyperbilirubinemia. This can increase risk of central apnea, desaturations, abnormal movements from brain damage, swallowing incoordination, and aspiration risk. High FiO2 increases the risk of retinopathy of prematurity, which can lead to retinal detachment, a common cause of blindness in children. Avoid exposure to high FiO2. Regarding endocrine implications, this includes risk of hypo and hyperglycemia. Hypoglycemia results from minimal glycogen reserves, limited ketogenesis and lipolysis, and perioperative starvation. Avoid excessive starvation and provide glucose supplementation as appropriate. Hyperglycemia may occur due to incomplete suppression of hepatic glucose production and defective insulin secretion. Sepsis, drugs, high rate of glucose-containing IV solutions, and stress hormones increases the risk of hyperglycemia. Hyperglycemia is associated with mortality and morbidity, including ROP and IVH. Blood glucose should be monitored and maintained within agreed limits, usually 4 to 8 millimoles per liter. Hyperglycemia can also lead to dehydration from diuresis. Pharmacological implications of prematurity. Regarding drug absorption, via the oral route, there may be reduced absorption via oral route due to vomiting or reflux. There may be increased absorption via oral route due to reduced intestinal transit speed. Increased VA to FRC ratio compared to adults results in increased rate of rise of FAFI of volatile anesthetics. Increased muscle blood flow increases the rate of absorption of IM-administered drugs. Increased skin blood flow due to increased cardiac output increases the rate of absorption of subcutaneous and transdermally administered drugs. Regarding distribution of drugs, increased cardiac output results in increased rate of onset of IV medications. Increased blood volume and total body water increases volume of distribution of water-soluble drugs, such as muscle relaxants. However, this is often offset by increased end organ sensitivity and reduced clearance. Reduced blood fat content reduces blood gas partition coefficient of volatile anesthetics. Acidosis increases ionization of basic drugs, such as bupivacaine, which reduces toxicity. Reduced albumin increases percent of free acidic drugs, increasing toxicity. Reduced AAG increases percentage of free basic drugs, increasing toxicity. Reduced muscle mass increases sensitivity to muscle relaxants. Reduced fat mass reduces uptake of lipid-soluble drugs, which increases toxicity, such as bupivacaine. Immature and more permeable blood-brain barrier increases uptake of drugs into the brain, such as morphine and LA, increasing toxicity. Regarding metabolism and excretion, in general, drugs take longer to metabolize and eliminate, leading to accumulation and toxicity. Most enzyme systems have reduced activity, and renal elimination is reduced. Therefore, when possible, small increments should be used and titrated to effect. GI implications of prematurity. GE reflux is common due to underdevelopment of GE sphincter, increasing the risk of aspiration and apneas. Necrotizing enterocolitis. This is the most common GI emergency in the premature infant. This is due to immaturity of immune system and bowel structure. Triggers such as non-human milk feeds, antibiotics, hypoperfusion, anemia and hypoxia results in dysbiosis and hyperinflammatory response. Risk factors for NEC, prematurity, hypoxia, early feeding with formula milk, and colonization of gut with pathogenic bacteria. Presentation, abdominal distension, blood-stained stool, sepsis with possible gut perforation, intramural gas on abdominal X-ray, with or without portal venous gas. Complications include bowel perforation, peritonitis, DIVC, and septic shock. Management, largely supportive. Surgery is sometimes indicated either by inserting a peritoneal drain or performing laparotomy for bowel resection and proximal enterostomy. Renal implications of prematurity: impaired ability to concentrate urine, therefore they cannot tolerate under or over hydration. Water loss due to large body surface area and thin skin. Immature nephron function, resulting in abnormal electrolyte handling, acidosis, increased free water, and poor clearance of drugs and metabolites. There is increased risk of hyponatremia due to reduced urine concentrating ability, increased sodium excretion, and relative insensitivity to aldosterone. These patients may require sodium supplementation. Hematological implications of prematurity: risk of anemia. Premature neonates are born with lower HB and are unable to increase erythropoietin production appropriately. Other causes of anemia includes blood loss from phlebotomy, reduced red blood cell lifespan, and iron depletion owing to growth and suboptimal nutrition. Target hematocrit 40 to 45% in order to aid oxygen delivery. Increased fetal hemoglobin concentration results in left shift of oxygen delivery curve and reduced delivery of oxygen at tissue level. Although blood volume is relatively larger in mils per kg, absolute volume of blood is small, and small losses can cause significant cardiovascular instability. There is risk of coagulopathy due to both vitamin K and non-vitamin K dependent clotting factors being deficient and low platelet count. Pre-existing coagulopathy can be exacerbated by coexisting conditions such as sepsis and NEC. Musculoskeletal implications includes fragile skin, low subcutaneous fat, increasing the risk of thermal, chemical, and pressure injuries. There is need for careful positioning and padding. Metabolic implications in prematurity includes risk of hypothermia due to increased surface area to volume ratio, evaporative losses through the skin, reduced subcutaneous fat, immature thermogenesis due to reduced brown fat, and inability to shiver. Hypothermia is part of the little diamond, which consists of hypothermia, acidosis, coagulopathy, and hypocalcemia. Hypothermia increases the risk of apnea and hypoglycemia. B. What are the options for anesthesia in this case? This includes general anesthesia, spinal anesthesia, or caudal anesthesia. Regarding GA, RSI is rarely indicated. Gas induction may offer better control and reduce risk of desaturation over IV induction. Following standard intubation, positive pressure ventilation to reduce fatigue. Caudal analgesia or local infiltration by surgeons may reduce opioid requirements, resulting in reduced risk of apneas and opioid toxicity due to immature clearance. The surgery may also be performed under spinal anesthesia. Ideally, sedatives should be avoided. Regarding caudal anesthesia, this is rarely used alone due to short duration of anesthesia. Provide appropriate doses to avoid toxicity due to drug accumulation from reduced clearance. C. Discuss the advantages and disadvantages of general anesthesia for this child. Advantages includes regional anesthesia may produce suboptimal operating conditions in a moving baby. Use of sedatives to improve operating conditions under regional anesthesia increases the risk of post-op apneas in an ex-premature baby. Disadvantages of GA: possible difficult airway, increased risk of periods of desaturation, such as during induction, and consequent risk of hypoxemia. Ideally, GA is to be avoided in an oxygen-dependent baby with severe lung disease. General anesthesia does not have the inherent post-op analgesic effects of regional technique. Some evidence suggests increased risk of post-op apneas after GA. Excessive positive pressure ventilation may exacerbate right to left shunt and cause barotrauma to already damaged lungs. Comments: 28% pass rate. Candidates who organize their answer by systems tend to score well. These are my references. Thank you.